right. Hey guys, I'm Anna, one of the PGY4s, doing my senior lecture. Okay, so first of all, always wanted to be a doctor. So privileged and honored to have gone to med school, graduated, and ended up at the best residency program in the world with the best class in the world. And I can't believe we're about to graduate. Unreal. Hot tip if you want to start residency off right, you should pie your PD. But let's be real, residency is pretty hard. You can sometimes be unbearably tired. Sometimes you feel like you can't breathe. Sometimes you feel like you're drowning, like you're surrounded by sharks, or you're wrapped up so tight you can't escape. Everyone experiences residency differently. It all depends on who you are, how you cope. But one thing that I can say, as I've experienced, is that being a woman can affect how you experience residency and just medicine in general. So I'm going to talk about women in EM today. And I just want to preface, like, this is just, I'm gleaning from my own experience. This isn't meant to like devalue or ignore anybody else's challenges because we all face challenges. This is just, I'm talking about women's challenges. So I'm going to start with a little history. Women go back forever, and so does medicine. So women in medicine goes back forever, but I'm going to start in the 1800s when the first all-female medical college was opened in Boston in 1848. It was actually started by a guy who was like, I think it's pretty unnatural for men to attend to women during childbearing. So I'm going to open a school to train other women to help women during childbearing, which is kind of not the best reason, right? But either way, it was opened, and kind of in like the end of the night throughout the end of the 19th century, there was a big burgeoning feminist movement. So that kind of spurred the ability for more medical schools to open. And by 1910, a lot of formerly all male medical schools were now accepting females. I think we're all pretty familiar with Elizabeth Blackwell, the name Elizabeth Blackwell. Before an all-female med school opened, this fine lady decided she wanted to become a doctor because she felt women were treated better by other women. So she applied to all these med schools. She was rejected from all these med schools. And then kind of by a fluke, she was accepted to Geneva Medical College in upstate New York because they asked the men who were attending there, would you be okay with a woman coming to train with you? And they were like, sure, because they thought it was a joke. But either way, she went there. And then in 1849, she was the first woman in the US to receive a medical degree. And that kind of paved the way for other physicians, other females. This is a name that maybe we're less familiar with. Dr. Rebecca Lee Crumpler was the first Black woman to receive a medical degree in the US. So in the 1860s, there were 54,500 physicians in the US. Only 300 were women, and most schools blocked the admission of Black students. So she faced pretty overwhelming odds, but she was a nurse, and she was such a great nurse that a lot of people who worked with her wrote letters to school in the medical school in Boston, kind of like praising her work. And that's how she was ended up being able to attend the school and received her medical degree. And she did a lot of amazing things with it. In 1915, we have the first female national like medical association. At the time, it was called Medical Women's National Association. Now it's called AMWA, so it still exists. It was this lady, Van Hoosen. She wanted to join her local OBGYN society, but they told her she can't because she was a woman. So she decided to start her own society. A lot of women in the field actually were a little hesitant to have a society for women only because they thought they needed to like integrate themselves into the rest of the medical field, which was mainly men, and they thought it would like isolate them from that. But she was like, no, I'm going to do this. And so she did it. And it obviously gained a lot of popularity and is now one of the largest national women's associations. And then between the 1940s and 1970s, we see like a growth of women in the medical field, spurred a lot by World War II and women volunteering in World War II. And then in 1972, Congress passed Title IX, which was basically a piece of legislation that said if you're a federally funded institution, it's illegal for you to discriminate based on gender. So a lot of med schools that are federally funded were no longer allowed to reject applicants based on gender. So it allowed the number of entering female physicians to go from 6% to over 12% during this time. Then we just have, this is like one of the first organizations to create a library dedicated to medical texts available to women, which was shockingly not available before then. It still exists at Yale. In the 1990s, we see women start to take positions of leadership in the medical field. So in 1990, Antonia Novello was the first female to be appointed the US General Surgeon over 100 years after the position was established. And she's actually also the first Hispanic Latina to hold the position. And then in 1998, Nancy Auer was the first female president of ACEP. In 2014, something interesting happened. The AAMC actually published these like actionable guidelines to recruit, retain, and promote women in academic medicine. So before, there wasn't really any guidelines on like how to recruit women into the field. And so they took a bunch of data. They surveyed 117 US medical schools. They took this data, they synthesized it into this paper that was basically like, here's stuff you can actually do that's actionable to help like promote women in the field. And so it really changed the way a lot of institutions approached recruiting women into medicine. And by 2017, we see that women overtook men in like the ratio of matriculants into med school. So women, the number of female matriculants has since 2017 outnumbered the number of male matriculants in medical schools. So why am I giving you a history lesson? Why does this matter? So history in every field informs our present. So the challenges that women face in medicine today are informed by the historical context of women in medicine. And this informs how we experience medicine as a resident, and as a physician, and as a like post-resident physician, and as a patient. So I'm going to talk about these three different perspectives. So from our girls out there, or my boys, I don't know. Raise your hand if you've ever been called like Miss or Nurse or Sweetie or some other pet name by your patient, whether they're a man or a woman, or even other like staff members. Yeah, we're all raising our hands. What about you go up to your patient, you're like, hello, I'm Dr. Levitt. I will be your doctor today. And then like 30 seconds later, they're on the phone, like the nurse is here giving me an update. So yes, I see a hand hidden back there. So yeah, this is like a daily occurrence for us. It used to really, really bother me. It doesn't bother me much anymore. I kind of, got over it. I would just say like these things don't happen, for the most part. They're not like an intentional thing that patients are trying to insult you or demean you or anything like that. It's all based in this historical context of the path of women through medicine. So if you take it personally, it's just going to make you stressed out. It's just going to cause you more angst, and it's just going to make your day worse in the ED. So I encourage you not to take these things personally and just to know your own value as a doctor. But so we get some, the way we're treated by patients is different because we're women. What about from our superiors? So this was a study done at a 3-year ACGME residency in the US. They didn't disclose like the name of the program for confidentiality. But basically they gave surveys to like supervising physicians over a period of 3 years. And they looked at the differences in response from between male and female residents and between like year 1, year 2, year 3. And some of the results were interesting. So it showed that the surveys like reviewed both women and both female and male residents as equally capable in the beginning of residency. So when you're an intern and your role is still that more of like a student role, but by year 3, or year 4 for us, when you're more of like a colleague role, like when you're kind of moving out of that student role, men were seen as outperforming women. Furthermore, they found that in year 3 of residency, but not in year 1, women received more harsh criticism and less supportive feedback than their male counterparts. So one study, right? One program, does it mean much? I think for me personally, I have not felt like a difference between me and my male colleagues and like the criticism I receive or the feedback I receive. I do think like from intern year to fourth year, you should be receiving harsher criticism. That's a part of your growth in residency. You have more responsibility. You're expected to like be better. But I think like what's really encouraging for me is that this isn't a picture from intern year. Like we're surrounded by really strong female leaders, female physicians in our program, which is really awesome. Like every day I see my female attendings like kicking ass in the ED, you know, doing their thing. A lot of the attendings I look up to are females. And I do feel I receive support from both, you know, female and male colleagues all the time. Like I remember a time where someone was like yelling at me in the front, like nurse, nurse, nurse. And I was like, 1 second, sir. And Felipe was like, doctor, it's doctor. And I was like, thank you. You know, like it happens all the time. Like our people support us. I don't feel that in this program personally, but it's interesting to see, you know, there's data showing that maybe that's not the case outside of the comforting walls of Kings County, or maybe other people are experiencing residency differently. And I think it's worthwhile noting that. What about when you graduate, which is what we're all about to do? What happens when we leave Kings County? So more of like the physician post-residency perspective, I think it's important to look at the leadership. So even though women, medical students, like matriculants, female medical student matriculants outnumber their male counterparts, that's not reflected in leadership positions. And what's really interesting is that it's also there's also like a large salary disparity that evidence shows. So there was a study done that looked at EM physicians in specifically leadership roles. And it was shown that at the 5-year mark, women in leadership roles were paid 20 to 50K less than their male counterparts and worked like 40 or more clinical hours, 40 plus more clinical hours than their male counterparts. Again, like all the data I'm presenting is all from like studies that you always have to take with a grain of salt. They're like, you know, cross-sectional studies that aren't as great at giving like really good numbers that don't have confounding factors in them. But it's out there and it's like been reproduced, and this is interesting data. This was a study that just looked at EM physicians in general, looked at 95,000 EM physicians between 2019 and 2022. And it showed that female EM physicians were more likely to be single and have no kids than their male counterparts. And that, excuse me, that like family structure actually played a role in the pay gap between male and female EM physicians. So they did this like accumulated wealth over a period of 40 years. And they saw that if you were single and female, I mean, across the board, females were paid less, but if you were single and female, it was like 1.6 million less. If you were married and female, 2.5 million less, and then female with children, 3.1 million less. So, you know, what are the things contributing to this? There's a lot of different confounding factors, right? Like if you have kids and you're a woman, it's more like of a societal norm for you to stay at home and watch kids and work less. And, you know, these are generalizations, right? Like everybody has different experiences, but it's interesting to see that there's reproducible data that shows this is a thing. And so things like this can affect the attrition rate. So this was a study that showed, it was a cross-sectional study done over 2013 to 2020 of ABEM certified, board certified EM physicians. And it showed that the average age of attrition in females, so attrition is like when you leave. The average age of attrition for females was 44 and for males was 56. That's a 12-year difference. It's pretty big. And so like, why is this happening? Kind of like everything we've already talked about. Salary disparities, promotional discrepancies, sexual harassment, mistreatment in the workplace that is like primarily felt by female physicians. So all of this is to say, like, I'm not trying to complain. I'm just trying to like point out that this is a thing that we still face as a challenge and that everyone should be aware of it. Implicit bias like is rampant for everybody. But there's some things that show that maybe being a woman in medicine can give you an edge. So kind of moving on to the more like patient perspective. So this was a study done that was of US patients enrolled in Medicare treated in a hospital between 2016 to 2019. It had over 800,000 patients. And the primary outcomes they looked at were 30-day mortality and readmission rates. So like of note, this was done in a inpatient setting, so not in the emergency department setting, but still some pretty interesting data. It showed that patients, male or female, had lower 30-day mortality and readmission rates if they were treated by a female physician, and that it was felt more significantly by female patients. And that's basically what it's saying is like, for some reason, female physicians, their patients had lower mortality and readmission rates, but that it was felt more significantly with like a concordant relationship, like female-female. And it showed also like male-male had better like mortality readmission rates. So there's something about having concordant relationships, but also maybe something about being a woman. And like there's a lot of studies that show that women like they're not like the best quality studies, right? But there's a bunch of them that show like women may have better communication skills. They spend an average of like 2 more minutes per patient encounter, maybe can give better preventative recommendations, better discharge instructions, or like patients tend to like feel more connected, empathize more with a female physician. So like perhaps that's contributing to this data. And then like what's more interesting to me is that, yes, we all know like the gender of a patient affects decision making. Like it's just, that's a thing that we know, just like ethnicity, just like age, but that even the gender of the physician can affect decision making. So this is a pretty small study. I'm just bringing it up because it raises interesting ideas. It's a study that was done in Europe for EM physicians in Europe. Basically, over a period of 2 weeks, they presented a simulation. So again, simulation, so take it with a grain of salt, but of a male or a female patient with the same functionality status, and the physicians had to decide whether or not to intubate the patient. And it showed that if you were a female physician, you were less likely to intubate any of the patients, and that if you were a female patient, you were less likely to be intubated by any of the physicians. So we know like the gender of the patient, we understand that is something that there's implicit bias with our decision making for as far as like the patient. But what I found really interesting was like, just as a female physician, like, does that affect my decision making in the ED and I don't even know it? It's an interesting study. So again, like I went over all these data, I went over all these studies, history. It's just mainly to like highlight that challenges exist for everyone. This is just like an experience that I was able to speak from. And I think a lot of this data is like things that I'm going to experience once I leave Kings County. And that's why I think it's really important to be aware of it, because in the end, the solution is not just to complain about it, it's to be aware of it and to work together to understand how to overcome it. And there's actually a lot of amazing resources out there to help support women. I think last week at the NYC conference, they talked a lot about FemIEM. It's an awesome resource. Like the website's really cool. And then Academy for Women in Academic EM is through the SAEM, and it's like an EM specific women's group that has like a lot of career development, a lot of skill development, a lot of awesome networking. Of course, AMWA, we know the history now. And then there's like this Women in Medicine Summit that I actually didn't even know existed until I like researched for this lecture. It happens every year. Basically just women in medicine coming together, like talking about being a woman, doing like skills, professional development, all that awesome stuff. It's in Chicago, September 18th through 20th this year. Maybe check it out. But I think like what's important to realize is that, yeah, there's all these amazing resources out there. But as a resident, and I don't know, maybe as an attending, I think the most important resource you have is first your colleagues, you know, and your co-residents, but our admin, like our PDs and APDs, guys, it is like so not normal to have such an amazing group of PDs and APDs. Like people that actually want to help you, that actually listen to you, and that actually respond and like take action when you have an issue. It's not normal. So please like use your the people above you and realize that like you have this resource right now and it's like invaluable. So on to the sappy part. Just oop, sorry. Just want to thank my family, some of the amazing women in my life who have supported me throughout my journey in life and medicine. My niece, who's super cute. And obviously, I think residency would not have been the same if I didn't have the class I have. You guys are my support system, the people I laugh with, the people we cry together in the bar. We've gone through everything together. We've traveled together. And I think we'll continue that throughout life. You guys are lifelong friends, lifelong companions, and can't tell you how much you guys mean to me. And I think what's super amazing about County is that you get to meet people, you get to create relationships that you never would have otherwise. And I just really value that. The picture of me and Miss Mattis, who was a nurse on D4 North, like she was James and I's, like we call her auntie. She's like someone that is really inspiring to me. She's actually like coming to our wedding. We love her. And like, I mean, that's a relationship I never would have had without County. So just really realize you're in a unique community here. And then of course, can't go through a lecture without talking about this guy. My favorite person, my best friend, my biggest supporter, even though he's clutching that ultrasound machine right there. But residency wouldn't have been the same without you. Life wouldn't be the same without you. So thank you. And here's my sources.